Hi, this is Dr. Bueller, and we're going to continue our coverage of RNA viruses, talking about the influenza virus. As usual, I've got some pre-definitions for you to take a look at before the lecture. And as I've said before, there are several different RNA viruses. We've got coronaviruses that are including common cold, MERS and SARS, and SARS-CoV-2, Hep C, several different other viruses, and then influenza A and B. Our drug list for influenza is going to include different vaccinations, some neuraminidase blockers, our endonuclease inhibitors, and unfortunately that's about it. One extremely important thing is to differentiate between influenza virus itself and rhinoviruses that are often called common cold. A lot of people really confuse these and they call colds flus, and it's really important medically to know the difference. A cold is usually associated with upper respiratory symptoms, like a runny nose, sneezing, sore throat, sometimes coughing, but that's usually to do with mucus that's coming down from the runny nose. Fever isn't going to be that high. Influenza, on the other hand, has a much more severe systemic viral response. So very high fever, headache that can be really severe, muscle aches that can be severe, and severe tiredness and weakness and exhaustion. This can be to where someone just can't even get out of bed. We usually refer to influenza types A and B. There's also an influenza type C, but it's not really severe. It's more like the common cold, so we don't really worry about that as much. Influenza A is going to be the one that's going to cause most epidemics, and we name influenza A based on the spike types. So when you look at the virus itself, it's got a neuraminidase spike and it's got a hemagglutinin spike. And so the hemagglutinin is the H spike. It's involved in entry and fusion on going inside the cell, and neuraminidase, or the N spike, is involved in budding or leaving the cell. So there's multiple different forms of H spike, multiple different forms of N spike, and we name our type A viruses based on the combination of these. So you might have an H5N1 virus or an H1N2 virus, etc. The influenza type Bs we talk about in terms of their lineage. So type B, the location that they originated, and the year that they originated. Influenza A and B are going to infect cells upper respiratory tract and in the lungs. So our acute infection is going to be upper respiratory and lungs. And in more severe cases, what's going to happen is that the infection in the lungs is going to cause an inflammatory response. That's going to cause those lung cells to inflame. It's going to cause fluid to enter the alveoli, and that fluid in the lungs can make it difficult to breathe. But it can also then lead to bacterial infections inside that fluid, and that can lead to bacterial pneumonias. Generally, the people who are most likely to get a severe influenza infection or to get a severe secondary bacterial infection are going to be those people who are immunosuppressed. So we're talking about infants, the pregnant, the elderly, and people who are immunosuppressed for other reasons. It's an RNA virus, so it does not insert any of its genetic material into your genome. It doesn't stay inside your cells, so there's no chronic infection, which means that once your body has cleared that virus and killed it, it's gone completely. However, you can be reinfected with a different strain at a later time. That's not the same as a chronic infection. We do have vaccines available. We have both an inactive and a live attenuated vaccine, and our transmission mode is going to be air transmission. When we create influenza vaccines, we're going to make them with several strains in them. So usually there's 3, sometimes 4 different strains. Usually they're going to pick one type A H1N1 variety, one type A H3N2 variety, and a couple of different B lineages. There are going to be a lot more influenza varieties out there than these 4, and so the way epidemiologists have to determine which varieties are going to be within that year's vaccine is that they're going to look at the previous year and the new strains that have been developed and are coming out. So the likelihood of the occurrence then based on the global data. They're also going to look at those more likely viruses and look at how contagious each of them is and what the mortality rate is. So when you get this combination together, that's how they're going to determine which strains to put in. Every year you have to have new strains in there, and that's because there's a really rapid antigenic drift for RNA viruses. So that means that the mutation rate is very high, and each year you're going to end up having mutations that are going to make the previous year's vaccinations not effective. So as always, we're going to preview the influenza life cycle here so that when you watch the following video, that you're going to have some kind of roadmap to go by. As I said, the influenza virus has both H and N protein spikes. The way that the virus is going to enter the cell is that the H proteins are going to bind to sialic acids that are the receptors on the host cells. Then the host cell has to cleave that H protein here in order to bring the two membranes together. So you're going to have those host proteases that are cleaving it, as well as that host sialic acid that allowed it to bind to begin with. Once the virus is endocytosed, it's endocytosed within a vesicle, and the virus requires an acidic environment in order for the membrane of the virus and the membrane of the vesicle to fuse to allow uncoating. So the virus has what's called an M2 proton pump, and that's going to allow for the acidic environment. Once it uncoats, it's going to insert the viral RNA and a pre-made RNA to RNA pol. So as all viruses, it's going to use its own pol. In this case, that's that RNA to RNA viral polymerase in order to replicate the viral RNA into new RNA strands. Protein production is going to occur through that host cell ribosomes, but then a viral protease is required in order to cleave those viral polypeptides into active proteins. Once all the structural proteins, the new RNA, and the new RNA-RNA pol have been assembled, those are going to then be taken to the cell membrane, and budding can occur. At the final stages of budding, the cell membranes are still attached between the cell and the virus, and they're attached through proteins that are going to have to be cleaved in order for the virus to actually move off. So that N protein that we talked about, that enzyme neuraminidase, is that viral enzyme, and that's going to come in and it's going to cleave those attachment proteins. So once those are broken, then the virus can actually move away. So I want you to go ahead and watch this life cycle video. And this diagram is just here so you can highlight things and you can draw things in and take notes as the video goes. After watching that video, you're going to notice that there are some really clear similarities between coronavirus and influenza virus life cycles, and that's because they're both part of that larger RNA virus family. However, there are going to be some significant differences. The different external proteins, this S spike for coronaviruses versus the H protein, the N protein, and the M2 for influenza. Coronaviruses have one strand of RNA, while influenza viruses have 8 strands. Coronaviruses don't come in with pre-made RNA to RNA pol, so the first thing that a cell has to do is make that RNA-RNA pol. Influenza viruses come in with that pre-made and pre-packaged. Coronavirus has, when we looked at that cap snatching issue, where mRNAs have to have a particular cap on it that's going to allow human enzymes to work with that, the coronavirus can actually make its own cap. So it doesn't need to take the cap from our cells or our mRNA. Influenza viruses, on the other hand, don't make their own cap, so they basically steal it from our mRNA. So here's our mRNA with the cap, it's human, and then it has an enzyme that comes in, breaks that cap off, and then steals it and puts it on the viral mRNA. And that's called cap snatching. In coronaviruses, the RNA doesn't go into the nucleus, it stays in the cytoplasm, whereas in influenza viruses, it enters the nucleus. And we're not really sure on all the details of the budding mechanism of coronaviruses, while we know in influenza viruses that it needs that neuraminidase enzyme to cleave the proteins that are attaching that exocytosine virus to the host membrane. So now we're going to talk about the pharmacology and the different vaccines and drugs that we have for influenza. I mentioned before that we have several different types of influenza vaccines, and that each vaccine is going to contain antigens for several strains. So we can either have 3 strains in a trivalent vaccination or 4 strains in a quadrivalent. And we call them seasonal vaccines because they're being changed each year for the fall season. The injectable vaccinations are going to be inactivated whole virus, or they're going to be just the antigen protein itself. In this case, we're calling that a recombinant protein, and it's just that H spike, which is the protein that we use as our antigen for influenza. If you're not sure about the difference between the recombinant and the inactivated and live attenuated vaccines, please go back and review the lecture on vaccine types. Because none of these have live virus in them, then these are okay for immunodeficient patients. There's no way that you can be infected with the vaccine. The nasal spray, on the other hand, is made from live attenuated whole virus. So that is living virus, but it's been modified so that it's very weakened and very difficult for someone to become infected with it. It's going to use the same strains that the injectable ones use, but because we don't want to use it for anyone who's immunodeficient or has just a naturally lower immune response, we're not going to give it to infants or to adults that are over the age of 50. So it's only approved for children older than 24 months and adults under 50. And the reason for that was that we don't want anyone with a lower immune system to not be able to fight off that weakened virus. So we looked at that life cycle, and from that we can find drug targets. That viral attachment and docking stage that needed that H protein to bind to the sialic acid. There are investigations into drugs that could block that binding. The fusion and uncoating phase that requires that acidic environment, we're looking at drugs that can inhibit the M2 proton pump. And we used to have drugs that did that, and amantadine was one of those, but the viruses became resistant to that very quickly, so we no longer have drugs for that target. We can also look at purine synthesis. Humans also have to synthesize AMP and GMP, but our enzyme to do so is different enough from those of the influenza virus that we can block the influenza virus's enzyme without blocking ours. We can also try to target that mRNA transcription and regulation, and one of the drugs that we have right now is to block that cap-snatching endonuclease. And baloxavir, or Maboxyl, otherwise known as Xofluza, is our drug that we have out that does that. We can also try to create drugs that could inhibit the synthetic subunits of RNA pol. We can try to find protease inhibitors for the influenza virus, and we can try to inhibit assembly and budding steps. And so we do have a drug here that inhibits that neuraminidase enzyme, so that if you look up here at the right top corner, so that we can't cleave that attachment and then block release of the baby virus. So the drug that we have here is oseltamivir or Tamiflu. So like I said, there really aren't that many drugs for those endonuclease inhibitors. We've got baloxavir Maboxyl, and that is a prodrug to the active agent baloxavir. And the mechanism for that was inhibiting that cap-snatching endonuclease. That endonuclease is a subunit of the influenza RNA polymerase, but it is not the synthetic or replicating subunit. So by blocking this cap-snatching, we can't produce viral mRNA, and we can't have viral replication, and this is effective for both influenza A and B. Unfortunately, it does have to be taken early in the disease and has to be taken within 48 hours of the start of symptoms. The neuraminidase inhibitors are the other drug class, and we do have a few of them. We have peramivir, zanamivir, and oseltamivir, or Tamiflu, which is the more common one. These again are inhibiting that neuraminidase enzyme, blocking the budding or release of viruses, and works again on both influenza A and B. It also has to be taken early in the disease and has to be taken within 48 hours of the first symptoms.